Good afternoon. I would like to thank the organizers of the IDF conference for inviting me to give you this talk today, which relates to fungal disease in the setting of primary immunodeficiency. There are millions of fungi, and yet very few are really critically important with regards to human health. The list of infections, fungi that cause human disease is rather limited. So what we'll do today is go through into a structured kind of way of looking at fungi on the basis of their morphology, and also because they really segregate between different immunodeficiencies to filamentous molds, which are inhaled, to dimorphic fungi and yeasts. And the way I was structuring this to talk to you today was to go through certain immunodeficiencies that are associated with these fungi, so that we cover the vast majority of those diseases and what you guys need to know with regards to what to think when you see an infection with these fungi. So filamentous fungi or molds, the prototypic is Aspergillus. It comes into two morphological states: Candida, that we continuously inhale on a daily basis, and we all are able to control because of robust immune responses through neutrophils and monocytes and macrophages. In patients who don't have these immune responses being properly made, filamentation in these filament hypha forms can happen in tissue, which are the invasive forms of the fungus. That leads to angioinvasion. This is a blood vessel of a mouse that is infected with this GMS positive Aspergillus, occlusion of blood vessels, necrosis, which causes devastating clinical problems. So when it comes to inherited susceptibility to mold infections, the prototypic PID is obviously chronic granulomatous disease, which you're all aware of. However, over the last years, GATA2 deficiency, STAT1 gain of function mutations have emerged as important causes. We'll briefly talk about jobs that also causes mold disease, but a different flavor than CGD. And then there are patients also who develop these infections without yet known immunodeficiencies, and through exomes and genomes, we're actually very interested in understanding what their problems are. Very briefly, I will focus on CGD and jobs. So chronic granulomatous disease, about 40% of patients will develop invasive aspergillosis during their lifetime. When we look at other molds, scedosporium also can happen. Mucor is particularly rare in CGD for reasons that are not well understood. It obviously speaks to not all molds rely equally to ROS production for host defense. But mucor can happen when patients with CGD acquire or receive steroids. So 2 hits can actually get these patients in trouble with this mold. There's very few characteristic features of CGD-associated aspergillosis. One is the high prevalence of Aspergillus nidulans, which can cause devastating infections. And as opposed to Aspergillus fumigatus, that doesn't typically do this, Aspergillus nidulans invades through local tissue contiguous spread. You see here an infection that has eaten up the bone and the ribs, and as you can imagine, are very, very difficult to control. In 1991, interferon gamma was shown to actually, as prophylaxis, to prevent infections in CGDs, and this is one of the few FDA-approved indications for interferon gamma, certainly for immunotherapy, the only one. And that's something that is given to patients, but itraconazole or other azole prophylaxis is something that is also done in order to prevent these 40% lifetime risk with aspergillosis. Now, many of the infections in CGD with moldy infections are actually quite difficult to treat. And what I'm going to show you here is a couple of slides courtesy from Mark Parta and Harry Malek, showing transplantation in patients with CGD who have very difficult to treat otherwise infections. This is another example of Aspergillus nidulans. You see here in a PET an infection that is around the heart, in the spine as well. And just within a month, 6 weeks after transplant, this infection is gone. These are infections that do not respond to combination antifungal therapies, and Mark and Harry have really built up a sizable cohort showing that this can be done. And the sooner, of course, when it comes to mold disease is better with transplantation. As I mentioned earlier, Jobs syndrome caused by dominant negative STAT1, STAT3 mutations also predisposes to mold disease. However, here the problem is not reactive oxygen species production by neutrophils. Instead, it's a structural lung problem. These patients, as you well know, are particularly prone to develop suppurative lung disease, in this particular case, Staphylococcus, that leads to impaired remodeling that causes pneumatocysts or bronchiectasis. And then on those pneumatocysts, Aspergillus can happen. Aspergillus and Scedosporium are the two more common molds and can actually cause severe problems in the long run, including resistance to azoles. Going from molds to the second category of fungi I would like to discuss with you today is the endemic dimorphic fungi. Endemic because they're really geographically more restricted than the ubiquitous molds that are everywhere. And dimorphic because although the molds I showed you, they come in conidia and hyphae, so they're also dimorphic. The dimorphic fungi, which are prototypically shown here, Histoplasma and Paracocci, they come as molds in the environment, inhaled, and then in tissues, they become yeasts, as you can see here. So there are 6 major dimorphic fungi that can cause disease in inborn center of immunity, as shown here. And what's absolutely critical to remember here is what you've all learned through the years about what's important for handling mycobacteria in the macrophage. Which relies really heavily on the crosstalk between lymphocytes that produce interferon gamma that then binds to its receptors, activate JAK-STAT signaling to inhibit growth of intracellular pathogens within the macrophage, and then the macrophages make IL-12 that binds to its receptor on lymphocytes and creates this feed-forward loop that is absolutely critical for activation of the immune response to defend against intracellular pathogens. So some of the disease that cause mycobacterial infections, as well as listeria and salmonella, can also result in endemic fungal disease. Those relate to mutations in either 12 or its receptors, or gamma receptor 1, or within the cell, STAT1 gain of function mutations or GATA2. There are also autoantibody related problems, such as in the case of interferon gamma autoantibodies, as well as biologics that target gamma, such as emapalumab or TNF inhibitors that are well known also to cause susceptibility to disseminated infections by these fungi in the endemic areas. And besides the autoantibodies to interferon gamma that I briefly alluded to, there are also autoantibodies against GM-CSF that appear to particularly predispose against Cryptococcus, which is not a dimorphic fungus like histo, but it is an intramacrophage yeast, and we'll get back to that later on. So this is important to realize and look for when you have patients who have infections with these pathogens. In patients who have autoantibodies, Steve Holland's group here and others have used intense regimens with rituximab or anti-CD38, more recently targeted monoclonals, to decrease the titers of these autoantibodies with some clinical success. So in summary, inherited disorders that lead to these dimorphic fungal infections would include the ones that I showed you earlier, but also in the schematic wasn't shown, hyper IgE syndromes, whether dominant or recessive, for reasons in those particular cases that are not quite well understood at the mechanism level. One disease I would like to highlight here is STAT1 gain of function, that we'll also briefly mention at the very end of the talk as it relates to CMC, or chronic mucocutaneous candidiasis. But these patients also develop severe infections with these endemic fungi, and these are 2 examples of patients who had severe disseminated coccidiomycosis, again with horrible infections, as you see here. This is another example with significant bony involvement and multiple breakthroughs. And many of these patients, as you can see here, develop devastating bone involvement, and many do not survive. So the last but not least segment would relate to yeasts. And here are the two major yeast pathogens that we need to cover is Cryptococcus and Candida. So this is Cryptococcus, and when we see patients who develop cryptococcosis, we need to think of these entities here. So idiopathic CD4 lymphocytopenia, which is an entity of having HIV/AIDS without really having HIV/AIDS, so absence of CD4 T cells. As with HIV/AIDS patients, these patients can develop Cryptococcus, GATA2 deficiency, IL-12 receptor, STAT3 and DAC8 mutations. I alluded to GM-CSF autoantibodies earlier. And what's particularly interesting, as opposed to Cryptococcus neoformans, which is the most common cause of cryptococcosis, those appear in certain studies to particularly predispose to infections with Cryptococcus gattii, which is particularly prevalent in the west of the United States, as well as unknown immunodeficiency patients who do not fit yet a certain genetic paradigm with regards to why cryptococcosis happens. To end, we'll talk about Candida, which is a very common commensal. About 70% of us are colonized in our gastrointestinal tract and less often in the skin and the female genital tract with Candida. Candida comes into two flavors as well, the unicellular yeast forms. Then upon invasive tissue disease, filaments into these pseudohyphal forms where there's this pseudohyphae and then the budding of yeasts. Candida comes into two flavors. Invasive disease, that means Candida gets into the bloodstream and then it can get into deep tissues, or mucosal disease. And what's important to realize is that the host defense requirements for systemic or mucosal candidiasis are very, very different. We need neutrophils and monocytes, macrophages to defend against invasive disease. And mucosal host defense depends on lymphocytes. So starting with invasive candidiasis, the list of patients who have PIDs that result in invasive candidiasis is very short. So actually chronic granulomatous disease, as opposed to what I showed you earlier for Aspergillus, is not a very common etiology of invasive candidiasis. And when Candida happens in CGD patients, it often, for reasons that are not quite well understood, involves the lymph nodes. So it causes lymphadenitis, which is not a very common entity in other situations with invasive disease. In addition, complete MPO deficiency is an uncommon etiology for invasive candidiasis, typically though in the setting of a second hit such as diabetes. And more recently, and an important disease to cover briefly, is carnine deficiency, which you all need to be aware of when you see a patient that has any unusual invasive fungal infection, but especially when it comes to Candida in the CNS and in other areas, as I'll show you in just a minute. So if you don't believe me that neutrophils are important for the host defense against this fungus, what you can see here is a video of red being Candida in a live, at the time, kidney of a mouse, where Candida is going to filament, and then these gray cells will be neutrophils that will come and completely destroy the fungus. And not surprisingly, based on what I'm showing you here, patients who have quantitative or qualitative defects in neutrophils, they're at risk of getting these invasive candidiasis. So when it comes to a disease, a primary immunodeficiency, where there is quantitative and qualitative defects in neutrophils, we need to talk about carnine deficiency, as I mentioned. So carnine is sitting downstream of the C-type-lectin receptor pathway of pathorecognition receptors, such as dectin-1, dectin-2, MINCL, and others. It is a cascade of receptors that signal through Syk, spleen tyrosine kinase. It's important to remember this because there are now Syk inhibitors that are given in patients with different inflammatory and malignant diseases. And it's important to realize that those biologics are likely to cause the same diseases that I'm just going to show you here in a minute with regards to genetic carnine deficiency patients. What is very interesting about this disease is it causes selective susceptibility to fungal infections. And not only these patients only get fungal disease, but when they get fungal disease, they get fungal disease in very specific areas. For example, they get infections in their mucocutaneous sites and in the brain, but not in other places typically. So this is a girl that we saw here several years ago who had Candida meningoencephalitis as a result of that obstruction in the third and the fourth ventricle, a gigantic fourth ventricle that was compressing the brainstem and the cerebellum, caused by massive infiltration and patches of Candida. This is here third ventricle actually, so this is what we now call brain thrush. This girl required months and months of therapy at the NIH Clinical Center. She's actually doing quite well now after intense therapy and surgical interventions. The problem in this disease appears to be inability to recruit neutrophils at the site of infection, and then the neutrophils that come at the site of infection do not also function very well. So here is this particular patient who has that massive infiltration of fungi in the brain, and yet not many neutrophils in her CSF. And in addition to Candida in the brain, what we've come to realize through the years is that Aspergillus can happen in these patients, but interestingly enough, not involving the lungs, which is the typical site of entry. So this is a patient who had intra-abdominal and kidney, as well as brain Aspergillus, and again, associated with the absence of neutrophil response in tissue and a normal lung. So when you see patients who have extrapulmonary Aspergillus without a good reason, it's important to think of carnitine deficiency. The next couple of slides, I apologize for the way that these images look. This is actually onychomycosis causing fungi in patients with carnitine deficiency, causes horrible infections. Many patients have to have amputations or a bone marrow transplant to control it. And this other picture is from an unfortunate girl who came to us from Colombia who had pheohyphomycosis caused by Corenispora, which is a plant fungus, cucumber fungus, which had eaten up her face, as you see here, and extended into the brain with destruction of bone and major structures in her face. She did require bone marrow transplantation in order to control the fungus despite multiple antifungal agents. Unfortunately, developed CMV pneumonitis post-transplant and succumbed to that. My last 2-3 minutes, I'm going to end with mucosal Candida infections. We talked here about invasive disease and how neutrophils and macrophages are critical. At the level of the mucosa, what's important is to have lymphocytes, particularly those producing IL-17, as shown initially here in mice by Sarah Gaffen's group, with IL-17 receptor knockout mice not controlling the infection properly. And then diseases that have mutations in the IL-17 receptor or its downstream adapter, ACT1, reported by Jean-Laurent Casanova and Anne Puel, showing clearly that if you lack these axes in humans, you get chronic mucocutaneous candidiasis. You can also get skin staphylococcal disease and bacterial pneumonias. So if we look at what you need to consider when you see a patient who has chronic mucocutaneous candidiasis as far as PIDs goes, I mentioned the direct IL-17 receptor signaling mutations. And then there are other diseases, JOBS, STAT1 gain of function, air deficiency, DAC8, RF8, STK4, and others now, such as JUNK1 and others, that can cause varying degrees of decreased IL-17 producing T cells or responses that are impaired, or in the case of APOSED associated with autoantibodies against IL-17. What we've done over the last years in my lab is to phenocopy some of those indirect to IL-17 deficiency diseases in mice with air deficiency, STAT1 gain of function, DAC8 deficiency, and JOBS. We've come to realize that many of those have IL-17 deficiency as the exclusive factor, such as those I'm showing here, and some others that have no IL-17 deficiency or not that being the primary driver. So I'm going to end with a slide about air deficiency, the largest cohort of which we follow here at NIH, as I'll show, we'll have in the next talk, where what we come to realize is that actually in the mouse model of air deficiency, IL-17 signaling is normal. These mice don't typically have autoantibodies against IL-17, and yet they are susceptible. This is caused in the mouse by exuberant T-cell responses. Again, this is a disease of central immune tolerance, and as a result of that, negative selection of T-cells is impaired. These T-cells go into tissues and cause destruction, and it appears that in the tongue and the oral mucosa that also happens. And when you eliminate T-cells, candidiasis doesn't happen, and that goes through excess interferon gamma that impairs the epithelial barrier, so that if you genetically delete gamma from mare knockout mice or pharmacologically abrogate that axis, either targeting gamma or JAK-STAT signaling, you can actually control the infection, which has led us to propose a new conceptual framework of thinking of CMC syndromes as, on one hand, obviously having impaired resistance in the absence of IL-17, and on the other hand, is having excess immunopathology driven in this particular case by excessive interferon gamma, and obviously cases where both of those axes might be operational. So ending here, we have an increasing number of inborn errors of immunity, many of which are associated with fungal disease. These provide great opportunities to gain insight into host immune mechanisms, as well as give us lessons about adjunct immunotherapy and or transplantation, many of which these diseases really require intense immunotherapy, antibiotic therapy, and or transplantation to control the fungus. And many of those can be phenocopied by autoantibodies and biologics, but not all. And severe and or refractory infection by any of these fungi should always prompt investigation for host defects. And hopefully the framework that we went through today will be useful as you think through patients who might develop endemic dimorphic fungi, mold, or yeast infections. That, I'd like to thank you for your attention. I'll be happy to take the questions that come in the live Q&A that will follow this immediately after.
Hello, everyone. My name is Jennifer Orange, and I will be the moderator for our Q&A today. Before we begin the Q&A, please remember that each individual's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with questions concerning a medical condition. At this time, please join me in thanking Dr. Michail Lionakis from the National Institute of Allergy and Infectious Disease at NIH for that wonderful presentation. And we're saying welcome to the Q&A portion of the session. We've received some great questions, so we'll dive right in. The first question for Dr. Lionakis is, how much is our risk to black mold, specifically the one from India?
Thank you, Jennifer, and thanks the organizers for allowing us the opportunity to present some of these topics. I assume the question is about mucormycosis that, as we've all seen, is causing significant problems in patients with COVID, after COVID diagnosis in India. So I'll try to answer this both related to COVID and then in the setting of immunodeficiency, because it's not clear whether the question is for either or. So we haven't actually seen in this country a lot of mucormycosis following COVID, as it is seen in India. There are some unique risk factors associated with the development of mucormycosis, such as uncontrolled diabetes, the use of high-dose steroids, and it appears that the vast majority of patients in India following the COVID diagnosis that developed this devastating fungal infection had a significant proportion of them, over 80–90% of them, having both. So I think this appears to be the reason why there is enrichment. Now, whether that's of the medical system in India currently, a higher prevalence of uncontrolled diabetes, more use of corticosteroids during COVID or more prolonged, or other factors that might particularly predispose that population to mucormycosis, we do not really understand. But we haven't seen this infection after COVID in large numbers in here. As was mentioned earlier in the talk, in patients with chronic granulomatous disease who are typically at risk of developing these mold infections, primarily aspergillosis, mucormycosis is not a very common entity. So although mucormycosis can be seen in some patients with primary immunodeficiencies, now switching gears out of COVID, it is really not the most common mold infection we see in patients with primary immunodeficiencies that affect immunity.
Thank you very much. And thank you everyone for the questions that are coming in. Please keep them coming. The next question is, are there medications that are safe for use to fight Candida during pregnancy?
Yeah, this is a great question. There are now several classes of antifungals that we can use to treat Candida. They're in three major categories. It's amphotericin, which there's more to talk about in follow-up questions. There are the azoles, which are fluconazole, voriconazole, posaconazole, and then the echinocandins that are parenteral drugs, that is, they can only be used through a venous administration, such as caspofungin and micafungin. Among those drugs, the only class of antifungals that is actually safe in pregnancy is amphotericin B. So for serious infections, such as infections in the bloodstream with Candida, that would be the choice, because azoles and echinocandins have been shown to have fetal effects. And for topical infections, such as oral thrush or esophageal candidiasis, what we would typically do is use a topical application of amphotericin B in the setting of Swiss and swallow. Topical azoles are likely safe, and there have been some older studies in Europe indicating that topical miconazole is also well tolerated without fetal defects. But in general, we avoid systemic azoles. There have been recent studies showing that even a single dose of fluconazole for vaginal candidiasis in the first trimester can cause miscarriage and fetal problems. So we try to avoid azoles, systemic azoles during pregnancy, especially the first trimester.
Thank you very much. That's really good to know. Just to follow up on that, the next question is about the use of amphotericin to fight oral and esophageal candidiasis, and just the different ways you can take amphotericin. So
intravenous amphotericin can be used. It used to actually be used quite often, 20 years ago and before that, when we didn't have better options. Because amphotericin systemically is quite toxic, it can cause renal toxicity and infusion reactions. Unless we're compelled to use amphotericin because the other options are either not tolerated or there is a resistance, we actually avoid it most of the time. But amphotericin has been quite useful actually in patients who have chronic mucocutaneous candidiasis as a step-down therapy, as we call it. So after treatment for the acute phase of the infection with either fluconazole or an echinocandin, depending on the susceptibility profile. Then in patients who have very frequent relapses, what we tend to do is to put them on oral Swiss and swallow solution that works quite well to prevent relapses in those individuals. It doesn't work quite well for treatment of acute infection. That's why we usually do another drug like fluconazole or an echinocandin, and then we step down to oral amphotericin Swiss and swallow.
Great, thank you. The next question is, do any of these fungi that you've been discussing manifest in the nails, for example, the toenails?
So the classic fungal pathogens that cause annoying nail infections, even I would say outside of patients who have immunodeficiencies, 10% of the general population above the age of 50 would develop nail infections eventually, are the fungi called dermatophytes. So this is the most common fungus causing nail infections. Less often, other fungi such as Candida or molds that are not of that variety can also infect the nails. So these are the typical fungi that really infect the nails. And what's important to very briefly remember here is that usually topical therapy with antifungal drugs does not quite work for nail infections. And you really need a certain type of antifungal drug, typically terbinafine, which is given over months because it has very, very good nail penetration, is the drug of choice for these nail infections. It can have some liver toxicity, so it's always important to consult, obviously, with your physician with regards to whether it's a good idea to treat with this drug or not.
Thank you. The next question is, what's the best way to test for potential yeast in the body?
So the way we make a diagnosis is through culture. So an individual will have white coating over their tongue, or they will have an endoscopy and there will be white patches in the esophagus, or they would be vaginal yeast infection, or in certain patients, bloodstream infection with that. So the gold standard is a culture, and that's important for two reasons. One is it will tell us what the actual yeast species is. So Candida, which is the fungus that causes this infection, comes in different flavors. Candida albicans is the most common, but there are others. Depending on the species, there could be differences in the susceptibility profile, so that's important to do a culture. And we always do susceptibility testing in all of the Candida species as well, especially in patients with inherited immunodeficiencies, where repeated treatments with different drugs could, in some of them, result in resistance. So the best way is to get a culture, confirm that it is a fungus, name the fungus, and figure out what it is susceptible to.
Thank you. The next question is, can you talk about JAK inhibitors a little more? And are JAK inhibitors available?
So JAK inhibitors have become quite widely used over the last few years in the treatment of inflammatory, autoimmune, and other conditions. So JAKs or Janus kinases are important molecules that convey signals from the surface of the cell intracellularly to mediate a lot of inflammatory responses. And because a lot of these cytokines that can drive inflammation in certain diseases go through JAK signaling, the advent of these molecules that are very potent, they're used orally, so they're convenient in that regard. They have been used quite extensively in several diseases. Initially, these drugs were FDA approved for certain hematological malignancies, but now their use has really quite remarkably expanded in a lot of primary immunodeficiencies that have an inflammatory component. So there are several of them available. They're slightly different from each other. But in general, I think this is a class of drugs that we'll see much more in several diseases. And already there is evidence that in certain of them, they actually have quite good efficacy.
Thank you. The next question is, how do you treat chronic histoplasmosis?
So that's a great question. So histoplasma is one of those fungi that fall under the categories I showed you earlier of dimorphic fungi. They are molds behaving in the soil, and then when they get into the body, they become yeasts. So the drug of choice for chronic or maintenance or acute histoplasmosis even would be itraconazole, which is one of the triazoles. Now it's an older version of triazoles, and because the initial trials were done with itraconazole, that's why we still use it. So there's probably efficacy, although not formally controlled, trialed, kind of tested for other azoles as well, and many times we use those as well, such as posaconazole or voriconazole. But usually what happens with histoplasma patients is you start with amphotericin when they have a very severe infection, and then you step down to treat chronically with itraconazole.
Thank you. So this next question again goes back to the issue of how to diagnose what kind of fungus you have. So this question is, I was diagnosed with a fungus infection in my lungs a few years back. I have hypogammaglobulinemia and CVID and IgG subclass. They did testing, but they could never say what the fungus was. Is that usual?
So I'm going to answer, and then if that is incomplete, there could be a follow-up question to clarify. So I can imagine a scenario by which they maybe either did a bronchoscopy, where they may under the microscope on the lavage fluid they saw a fungal element that never grew, and as a result of that they couldn't make a diagnosis, or there was a biopsy in the lung where on pathology again there was visible fungal elements, but the culture didn't grow. These are not very common, but they're also not extraordinarily uncommon scenarios. Sometimes, depending on the fungus, their culture requirements could be tenuous. There could be material that is insufficient to grow. So we do see that on occasion. There are ways to go around that, molecular ways that, for example, if you see a fungus that doesn't grow, that you can make still the diagnosis with PCRs. So I would say it's not the most usual scenario, but sometimes we do face this, and there are ways in some settings to go around that.
Thank you. The next question is, does the long-term use of products like diflucan as preventative measure toward to control chronic systemic Candida infections cause any complications for patients with CVID?
So diflucan is fluconazole. This is a relatively benign medication from a toxicity standpoint. So the vast majority of patients who are on fluconazole are able to tolerate it quite well. Not every drug and every patient is different, so that doesn't obviously apply to every patient. But in general, fluconazole is well tolerated. There's a small % of patients who can get liver toxicity, but that is extremely uncommon relative to the other azoles that have the tendency to do that more often. So without knowing the specifics of this particular case, that is what is really the indication for being on chronic Candida treatment and what's the exact individual kind of history, it's hard to know and comment on. But in general, fluconazole is thought to be one of the best tolerated antifungal drugs for even long-term use. I will point out one thing here, as I kind of alluded to earlier, chronic use of antifungals without the guidance of an infectious disease expert can carry the risk of developing resistance, especially when it's interrupted and restarted. So it's always important in cases like this, when it is deemed important to be on chronic prophylaxis, to do that together with a physician who has experience with this.
Thank you. The next question is related, as it relates to CVID also, and it's, is there an ongoing medication to treat chronic yeast infections in patients with CVID?
I think this is an entity that is called, for the audience, chronic mucocutaneous candidiasis. Patients who would develop chronic recurrent Candida infections, typically in the mouth, sometimes in the esophagus, in the vagina, rarely in the skin. The way we approach this problem here in our group is dependent on the frequency of infections. For example, who would have a recurrence once a year or every 2 years, we treat the acute episode for a minimum of 4 weeks. It's important to not treat shorter than 3-4 weeks because the relapse rate in our experience is quite high. And then we do not put the patients on an ongoing medication because we feel that once every 2 years or once every year or every 9 months to treat is sufficient, as opposed to keep a patient on secondary, as we call it, prophylaxis. Now, in the scenario, which is, it can be common depending on the underlying disease, where a patient gets treated properly and then soon after stopping antifungals, there is relapse. We do transition the patients to chronic prophylaxis. And as I mentioned earlier, in those cases, we try to avoid systemic antifungals, and we typically go to an oral solution of amphotericin if we're talking about oral and esophageal candidiasis, in order to avoid chronic exposure of drugs that could cause resistance in some settings or toxicity in other settings. So that's how, in general, we approach this, but it always comes down to the individual patient, what's the underlying disease, the frequency, what's the Candida species. So it's not a straightforward one-fits-all answer.
Thank you. And just to confirm, Dr. Lionakis, to refer back to the individual who had the undiagnosed kind of fungus in their lungs, they did confirm that they had a scope and a biopsy.
In this setting, what we would do is we will actually get DNA from that biopsy and try to sequence the fungus, even if it never grew. So there are, again, ways where we could still get some information to try to tailor it to the patient. Great.
I see I think we have about 4 minutes left. Is that right? So I'm going to try and get through another few questions because there have been a number that have come in. Why do I get numerous yeast infections, both vaginal and skin? Is it due to the immune deficiency?
Usually the recurrent nature of fungal infections in the skin, the oral, vaginal mucosa, is a marker or a biomarker of not a proper immune response against the fungus in the mucosal surface. I would say for vaginal disease specifically, the criteria are a little bit more different and the threshold is different. Why? Because almost three out of 4 women worldwide will develop vaginal candidiasis, and at least half of them will develop at least another recurrence. So for vaginal disease, there's a significant proportion of women that can actually have a few episodes here and there without that meaning that they have an underlying immunodeficiency. However, if those episodes are very frequent, or if there is oral or skin involvement, recurrent and or refractory to therapy, that typically means that the ability of the body to handle those infections in the mucosal surfaces is compromised. And an evaluation in those cases is I think, imperative in order to see whether there is an element of that. The treatment, as I outlined earlier, depends on the individual and how frequent and severe those infections are. But typically that means that there is an immune defect that allows for that to happen.
Thank you. The next question is, Dr. Lionakis, you mentioned that the family of fungi that commonly affect nails is treated with a penetrating medication. In our case, the skin fungal infection on foot and affected nails responds well to fluconazole doses. Is it good to continue to use this, or should we get confirmation of which fungal infection is affecting skin and nails separately? Liver function tests remain normal with maintenance dose. Thank you.
When something works and it's well tolerated, it's always a good idea to stick to that and not try to change things. The fact that this responded to it highly suggests that the likely etiology of the fungal infection is probably Candida, because usually fluconazole doesn't work quite well for some of those dermatophytes. So that is not the majority of nail infections, but they can be caused by Candida, and fluconazole works and LFTs are normal. That's fine as well.
I have 1 minute left, so I'm going to ask this last question. How would someone get evaluated by the NIH for the cause of fungal infections?
It's very simple. They send us an email, and we will be delighted to evaluate them and see them here if they want to come, or work with our local physicians in order to identify ways, if there is difficulty in travel, to work with their physicians to help them locally. So that's the simplest answer to that, given the time also.
Thank you very much. So our time has come to an end. Thank you everyone for your questions. And thank you so very much to Dr. Lionakis. It's been an honor to have you join us today, and enjoy the rest of the conference, everyone.